I wish you all a happy new year, and hopefully it will be a healthy and prosperous one for all of you. Let me begin by asking the directors to introduce themselves, or at least to respond to Marcin's call for a role. This is Charlie Klippel, Chair of the Board.
Mr. Chair, yeah, I will call for the board attendance, but before we do that, I would just like to mention that this meeting is being recorded for the minute-taking purposes, as well as for the posting of the recording of the proceedings on the agency's website. This meeting is also being live streamed on the Access Health CT website. It is also requested that participants introduce themselves every time they speak. Roll call votes will be taken for every action item. Roll call for attendance. Charles Klippel, Chair.
Yes, here. Thank you.
Paul Philpott, the Vice Chair.
Here.
Grant Rader.
Here.
Dieter Gifford. Steven Hernandez. Matthew Brackman. Thomas McNeil. Mr. McNeil.
I see him.
Yes, we do see Mr.
Maybe on
McNeil.
mute.
Yes, we do see Mr. McNeil. Dina Berlin. Ms. Berlin. Deputy DSS Commissioner Peter Hadler.
Here, thanks.
Thank you. Sean King, OHA.
I'm here.
Morning. Thank you. Claudio Galtieri, OPM. Paul Lombardo, Connecticut Insurance Department. Dr. Manisha Chutani, DPH Commissioner. Caroline Zambetti, designee for Nancy Navarrete, DMS Commissioner.
Here.
Thank you. And I believe Mr. Hernandez just joined us. Mr. Hernandez,
Yes,
are
thank
you
you. I'm here.
present? Thank you. And
present.
thank you. And Mr. McNeil, once again, we'll try to get your attendance. Mr. McNeil, are you present?
Tom, we're having trouble hearing you, so maybe you could just raise your hand or give us a little sign. No. Well, we know he's
Okay.
present. So.
Okay, thank you.
All right.
That concludes the roll call for attendance.
Thank you very much, Marcin. And I understand that we have no public comment today. So we will move on. And I'm sorry. I've asked the executives of of Access Health to introduce themselves. Thank you.
Thank you, Mr. Chairman. Good morning, all. James Michelle, Access Health Connecticut.
Gina Walsh, Director of Operations, Access Health Connecticut.
Holly Zwick, Director of Finance, Access Health Connecticut.
Rebecca McClear, Director of Technical Operations and Analytics, Access Health Connecticut.
Susan Rich-By, Director of Legal and Governmental Affairs, Access Health Connecticut.
Caroline Rouette, Director of Marketing, Access Health Connecticut.
Don Carbone, Director of Small Group Product Development and Broker Support, Access Health Connecticut.
Good morning, Glenn Jurgen, Director of Human Resources with Access Health Connecticut.
Good morning, Tammy Hendricks, Director of Health Equity and Outreach, Access Health Connecticut.
Good morning, soon to be retired Director of IT, Janelle Maloney.
Marquise Davis, Director of IT, Access Health Connecticut.
Thank you. Thank you all. I like the soon to be retired. We will return to that theme in a moment, but we'll start by congratulating you on your soon to be retirement. Thanks very much. I believe our first order of business is to approve the minutes of the last meeting. Are there any comments or discussion on the minutes of the last meeting?
Mr. Chair, we received no public comment. Okay, so.
Yes, thank you very much.
Mm-hmm.
So then I think, is it appropriate to ask for comments or questions on the minutes of the last meeting? And hearing none, I would ask for a motion to approve the minutes of the last meeting.
Yeah, this is Grant. Motion to approve.
Thank you, Grant. Second?
This is Sean. I'll second.
Thank you, Sean. Charles, any further comment? No. Charles Klippel, yes. Thank you.
Okay. Paul Philpott,
Yes.
Grant Ritter,
Yes.
Dietrich Gifford, Steve Hernandez,
Yes.
Matthew Brackman,
Yes.
Thomas McNeil,
I abstained. I wasn't here for the last meeting.
Okay. Dina Berlin.
Yes.
Thank you. Peter Hadler,
Yes.
Sean King,
Yes.
and Claudia Gaultieri. Thank you. Motion passes.
Our next item of business is to elect, and in this case, re-elect a vice chair for the board, Susan Rich-Bai.
Thank you, Mr. Chair. The bylaws of the exchange state that each year the board shall elect a chair on an annual basis, and we have always done it at the January meeting. So it is time for you all to nominate and elect a vice chair, excuse me. Thank you.
And I am told, hopefully correctly, Paul Philpott, that you are willing to serve in this position again. And I would be personally delighted, and I think everybody else would be too, if you do that. So I am pleased to nominate Paul Philpott for the role. Are there any other nominations?
First you need to second that. This is Grant. I'll second that.
Thank you, Grant. Any other nominations we should consider? Hearing none, then I'll take the nomination the second and request your vote to approve Paul Philpott as the vice chair of the board. Susan, unless I've done the formalities wrong, is that good enough? And if so, Charles Klippel, yes.
Mr. Chair, would like to make a motion for that, and we have to second the motion.
Oh, sorry. I will also move to make Paul Philpott the chair of the vice chair of the board. And
thank you.
So, second.
This is Grant. Second.
Yep. Thank you, Grant. Very much appreciated. Okay, now I think we can do our vote. Are we okay, Marcia?
That's correct. Charles Klippel.
Yes.
Paul Philpott.
Yes.
Grant Ritter.
Yes.
Dietrich Gifford. Steve Hernandez.
Yes.
Matthew Brackman.
Yes.
Thomas McNeil.
Yes.
Dina Berlin.
Yes.
Thank you. Peter Hadler.
Yes.
Sean King.
Yes.
And Claudia Gaultieri. Thank you.
Thank you.
Motion passes.
Paul, thank you very much for your service, for your ongoing service to the Access Health. You've been an enormous asset to this board, and we appreciate your continue to serve. Thank you.
It's been my privilege. Thank you.
James, the floor is yours now.
Thank you, Mr. Chair. Good morning, all, and a happy new year to all. I'm James Michel, the CEO of Access Health Connecticut, and thank you for being with us this morning. Before I begin, let me just make a couple quick announcements. Janelle, as Janelle had indicated, she will be retiring early February, and we were very fortunate to hire Marquise Davis, who comes to us with extensive experience in the IT management space. So he will have a couple of weeks, several weeks for transitioning between him and Janelle. As you know, we have a very complex technology solution to help Connecticut residents get access to health insurance. So we are very fortunate to be able to have the two of them work together for 3 to 4 weeks while we transition from Janelle to Marquis, so he could learn all the unique ways how our system works and all the partners that we connect with on a regular basis between DSS, BITS, and the federal government. So welcome, Marquis, and obviously we will wish Janelle the very best as she moves on to this next phase of her life. Mr. Chairman.
Let me just interrupt you briefly, James, to sort of echo your last thought. Janelle, thank you so much for your service to the organization and to all the great information you've provided to this board for the time that at least I've been chairman, and before that as well. You've been very helpful to us in understanding that complex environment that James discussed, and we wish you all the best in your next endeavors. Thanks.
Thank you very much. I appreciate all the well wishes.
Thank you all. So before we begin, I want to share some good news about our most recently completed open enrollment. We saw record-breaking enrollment for 2024. We exceeded our previous highest enrollment numbers, which was at 116,000 on our year 3 across the board, with more than 129,000 connected residents enrolled in qualified health plans through Access Health. Our standalone dental plans also saw significant increases with over 14,000 customers now enrolled. Last year, we were at a little bit over 6,000. There are several factors driving these increases. We invested in a targeted marketing and outreach campaign with our efforts focused on the underserved communities, as well as the underinsured populations of Connecticut. The Medicaid unwinding process has substantially impacted enrollment numbers as well. Cover Connecticut was a big contributor to the increase in enrollees. We have worked to establish additional brokers across the state of Connecticut to help residents with the application process. And we had a number of graduates from our broker academy connecting with customers at all of our in-person events throughout the year. I'm very proud of the work our team has done to achieve these numbers. For our meeting today, John Carbone, Director of Shop and Product Development, will give an update. We'll give an overview of an alternative employer coverage option called Individual Coverage Health Reimbursement Arrangement, also known as ICHRA. John will review what ICHRA is and why we believe it is a viable, beneficial option for Connecticut businesses, especially the small businesses who want to offer health insurance coverage to their employees. Next, Rebecca McClure, Director of Technical Operations and Analytics, will give an open enrollment update. Open enrollment ended on January 15th, as you know, but we will have a full detailed analysis report in February, which will be emailed to the board as soon as it is completed. So this is an overview. This past Monday was the last day of open enrollment. Then Caroline Rubert, Director of Marketing, will join Rebecca to share the result of the Lever survey. Last fall, we surveyed Connecticut residents affected by the Medicaid unwinding who do not currently have Medicaid coverage and have not enrolled in health plans through Access Health. We want to know exactly why they did not enroll. The results show that most of these Connecticut residents now have insurance through employment or a spouse. Some of them have aged out of Access Health into Medicare. And a number of them made it clear to us that the insurance available to them is not affordable. Also, a small number of them have moved out of Connecticut, as many of them that came in during COVID. Some went back to some of the states that they came from. Following that, Julia Andrews of Wakely Consulting will present the annual Adverse Selection Study report. To conclude the meeting, Susan Richby, Director of Legal and Government Affairs, will discuss the 2-month premium initiative from the state of Connecticut, and also give a quick update on the Health Plan Benefit and Qualification Advisory Committee for plan year 2025. Mr. Chairman, thank you very much, and the board for your continued support. I think the success we had for the 2024 enrollment period clearly came from the support that we had from the board last year. The board allowed us to spend $2.7 million for outreach and marketing, specifically for the unwinding, and we are seeing the result of that effort, and we greatly appreciate the board's support in doing so. I will now pause for questions before we move on. Thank you all.
Thank you, James. Rebecca, if you would give us the open enrollment update, that would be great. Thank you.
Sure. Thank you, Mr. Chair. Again, this is Rebecca McClear, Director of Technical Operations and Analytics at Access Health Connecticut. And as James mentioned, this year's open enrollment period did just conclude on Monday. So we are still in the process of pulling together all of our analytics and our reporting, but we did want to share some of those highlights with you all at this time. So let's see, we'll start off with our call center activity this year. Our call center vendor since November 1st has handled over 260,000 phone calls and over 24,000 chat sessions. That's an increase on both counts over this time last year. However, that increase is aligned with what we have been seeing throughout the Medicaid unwind period. So Access Health and DSS, the Department of Social Services, have been working with our call center vendor, TTEC, to ensure their staffing is increased accordingly to handle that increased volume throughout the Medicaid unwind period, as well as open enrollment. This year, as James mentioned, we had 129,000 individuals enrolled in a qualified health plan during our open enrollment period. That is about a 20% increase over last year. And as James also mentioned, our highest end of open enrollment volume to date, eclipsing our previous high of 116,000. So we're very excited about that and all the work that our teams across the board have done to get us to that point. Also, due to the Medicaid unwinding, the number of individuals enrolled in the Covered Connecticut program did nearly double to just over 27,000 individuals. 25% of those did not have any QHP coverage through the exchange in 2023. So again, quite a significant increase in enrollment in that program, largely due to that Medicaid unwind process. If you recall last year for our standalone dental program, we incorporated that into our medical platform. So this year was the first year that we were able to auto renew those individuals into that dental program. So to make it easier for consumers to enroll as well as maintain their coverage. As a result, dental enrollment did increase by over 55% to just over 14,000. Just for reference, prior to integration, so a couple of years ago, our enrollment did peak at about 4,500 individuals. So clearly a large increase there as well. And we are seeing a vast majority of those individuals retaining that coverage throughout the plan year for last year. So again, great performance there. Just a quick update that those dental individuals, that is about 10% obviously of our overall health enrollees are enrolled in a dental plan. That's great to see as well. And we did have just shy of 1,000 individuals enroll in a dental plan only through the exchange. So those individuals may have medical coverage through an employer or through Medicare and chose to purchase a dental plan through the exchange. So again, great options available to our residents. Looking at financial assistance, we see the 88.3% of the enrollees this year are eligible for financial help. That continues to increase year over year. It's about 2.5% up from last year. And Access Health continues to pay attention to that portion of the population who either indicates that they do not wish to have financial help or for some reason are not determined eligible, to ensure that we are doing everything we can to make sure they're getting taking full advantage of the benefits that they are eligible for. And finally, this year, we did see a significant increase in the volume of individuals coming to the exchange and being determined eligible for Medicaid. Again, part of that is due to the Medicaid unwind, but it's also due to the increased communication and outreach to the communities by both the Department of Social Services and Access Health staff. So great news all the way around there. Questions on this slide before we move on? Okay, hearing none. Martin? Okay, moving on to the demographics. Population, again, about 90% of that dental population is enrolled in medical. So the demographics of that population are included within this. I'm not separating out medical and dental for the demographics discussion. So the average age of our enrollees this year has gone down slightly to 43 years old. A good reason for that is we did see an increase in the number of individuals in the 19 to 25-year-old age range. enrolled this year over last year. That increased significantly. So it did bring the overall age down. In addition, the household size did decrease. Normally, traditionally, we have about 2.2 individuals per household enrolled in a QHP medical plan. This year, it's down to 1.4. Again, looking at the population, it looks like a lot of those younger individuals have a household of one, so that did bring the average household size down. Finally, we do continue to see most of the enrollees come from the 3 main counties of Fairfield, Hartford, and New Haven. However, we did see significant growth in Windham and New London counties. The proportion of enrollment was up 8% and 6.4% respectively. So we are seeing some of those other counties come up and get some additional enrollment from those areas. Coming down to their plan selections and premiums. Overall, we continue to see an increase in the number of consumers associated with a broker across all counties. Over 50% of the enrollees coming from Fairfield and New Haven County indicated that they had the assistance of a broker to ensure that they were choosing the plan that is right for them and their family. But again, we did see increases across all counties. As James mentioned, our broker academy and our broker support team working very closely with all of our brokers to make sure they're going out and working with those consumers is really showing up in the numbers here. Silver plans continue to be the most popular for our consumers, with 53% of enrollees selecting a silver plan. This is the 4th consecutive year that we've seen an increase in the selection of silver. Overall, 20% of folks enrolled in a silver plan did not have coverage last year. So again, that is a sign that the Medicaid unwind and our increased marketing and outreach have continued to bring those folks onto the exchange. With regards to premium, we'll see that the median monthly gross premium, which is the monthly premium prior to any application of subsidies, is $8 this year, and the median monthly net premium, or premium minus the subsidies, is $78. These are down from last year. Last year's numbers were $847 and $94 after APTC. So again, looking at those numbers, the increase in the covered Connecticut volume, which includes both the APTC and the state payment of the month member responsibility amount, brings that down significantly. Finally, looking at our retention rate, the retention rate actually stayed pretty steady for last year, by 86% retained in the QHP, which is a great number. But 91% of those that retained their coverage did stay in the same metal level plan for 2024. We didn't have a lot of movement across those metal levels. So that is consistent with prior plan years.
Thank you, Rebecca.
And one more, sorry, thank you. The last one, just a couple quick updates, reminders for folks. So initial premium payments are consumers, in order to use their policy, they do need to pay that first month's premium. So that the invoices have been delivered and they will need to pay that. Right now, 85% of our medical enrollees have paid their January or February, depending, premium for their first month premium. And we have a little bit lower on the dental policies, mainly because of the increased volume. They have a little longer to pay that premium. So we're hoping that that increases as we get closer to the end of January. From a 1095 perspective, those forms will be sent to our consumers shortly after January 24th. And these forms will allow the consumers to reconcile their taxes when they're filing their 2023 taxes. Customers can retrieve those electronically from their consumer account on our website. And in the event that they need assistance with those forms, our staff is ramping up to address the issues for the duration of the tax season. One last reminder, as James mentioned, we will be sharing this full summary report next month as soon as it's completed via email out to the board, and we will present at our next regularly scheduled board meeting. Thank you so much.
Any questions for Rebecca? Appreciate it.
Charlie, it's
comments?
Paul, I've got a question.
Yes, please. Please, Paul.
Okay. My question is, when brokers call, are those calls handled separately from the regular queue?
So, Paul, this past year, our call center was overwhelmed. So what we did was we have a team within Access Health, our broker support team. And that's all they did throughout the enrollment period. So when brokers call, they are directed to our team. So take the pressure off the call center. The call center is supposed to handle those calls. So they are trained to do it, but they were overwhelmed because of that. We took that on ourselves this past year, and the results were pretty good with respect to with respect to how the brokers accepted the additional support that we supported from. So it is a different queue from the call center.
Okay.
From the call center, yes.
Yeah. So, these guys bring in half our business. So I think we need to make sure that we're measuring the key performance indicators when they call us. So, I understand having to take some emergency measures this year, so to speak. But I think at some point we need to formalize some kind of a queue for these guys and measure it. And then my last thing isn't a question, it's a comment, and that is that the numbers are impressive. Congratulations. I think most impressive was the growth in the dental plan of 14,000. That's an amazing job. So congratulations.
Thank you, Paul.
Hear, hear. Any other comments or questions? Rebecca, thank you very much. Actually, I have to say, the number that impresses me is the Cover Connecticut number. I think through a lot of the hard work of this team, you have gotten the word out effectively, and it's great to see that the program has the uptake it has. So thank you all, and thank you, Rebecca. John?
Good morning, everybody. Hope everybody's doing well. John Carbone, Director of Broker Support, Product Development, and Small Group. So as many of you know, over the past several months, we've been exploring the potential of introducing a new offering for small business owners and their employees called ICHRA, Individual Coverage Health Reimbursement Arrangements. We'd like to talk a little bit about this in more detail today, explain how this works, and the potential that it has for Access Health and the small business community. Over the past 8 years, our small business group health insurance market has shrunk by more than 60%. And because of this, we recognize that there's not only an opportunity for this product, but a need. Today's employees expect health insurance, but with rising costs, employers find it challenging to offer traditional group plans and need flexibility and more choice. We know that this can be the new flexible option that gives the employers and employees the ability to offer a plan that works within their budget, access to better plans in a platform, and have more ownership of their healthcare coverage throughout the year. Ultimately, this will lead to the reduced number of those that are uninsured. This will reduce the number of those that are uninsured and a healthier population. So now I'd like to walk you through what an ICHRA is for those that are not as familiar, then go through the journey on how this works from a standpoint of the employee, show the overall benefits for the employee and the employer, and what our next steps are. So what is an individual coverage health reimbursement arrangement, also known as ICHRA? An individual coverage health reimbursement arrangement, available as of 2019, is a type of health reimbursement arrangement in which an employer of any size group can reimburse an employee for some or all of the premium that the employee pays for an individual insurance plan that they purchase on their own. ICHRA represents a departure of the previous ACA implementation rules that forbids an employer from reimbursing an employee for individual market premiums. Qualified small employer health reimbursement arrangements, also known as ICHRA, which became available in 2017 allows small business employers 50 and under to reimburse employees for individual market premiums, but ICRA will allow this employer of any size and have more flexibility in terms of how much that employer is allowed to reimburse for those premiums. So at this point, I'd like to walk you through a very high-level journey of an employee called Mike. Challenge. Mike's employer offers health insurance, but with rising health insurance costs, the group coverage is no longer affordable. The opportunity for Mike. Next slide, Marcin. A challenge in several federal regulations, including the IRS tax code, allows Mike's employer to help offset the cost of the individual plan. How it works. Mike's employer makes a decision to offer an ICRA plan, which the employer's pre-tax dollars to a class of employees that includes Mike. The ICRA offer to Mike will help him pay for healthcare coverage available through Access Health. ICRA contribution rules work the same way as the rules for the federal financial help and employee contribution and the employer contribution towards an employer health insurance plan. Using the Access Health ICRA platform, Mike's employer will work with their broker to determine if the ICRA offer to Mike is considered affordable. If the ICRA is affordable, Mike can enroll in a health plan from Access Health and seek reimbursement from the ICRA, but is not eligible for financial help in the form of advanced premium tax credits or cost sharing reductions through Access Health. If the ICRA is considered affordable for Mike, he could be eligible for financial help to buy a health plan offered through Access Health, and his employer and broker can use the Access Health, it can use the ICRA platform to help Mike seek this determination. Mike is eligible and wants to receive financial help through Access Health, he will have to opt out of receiving the ICRA contribution from his employer. Next slide, Marcin. One more. So here's Mike's journey throughout the whole entire process. All right. Mike, healthcare coverage options are evaluated by the employer and the ICRA is chosen. Employers get to set up on an ICRA platform. Employers classify each employee based on 10 permissible types of classes. Here are a few examples of those classes: part-time, full-time, seasonal employees, temporary employees, salary employees, hourly employees, employees under a collective bargaining agreement. Mike's eligibility for group versus individual with an ICRA is determined by his employer through the initial analysis. Employee education begins on our ICRA platform. Mike shops the Access Health portal and chooses the best plan that's right for him. How does this benefit Mike? Mike enjoys the reduced healthcare coverage costs thanks to his employee's pre-tax contribution into the ICRA or possible federal subsidies if eligible, but not both. With 22 plans to choose from, Mike has the freedom to choose the healthcare coverage that best fits his needs at the right price point. How does this help the employer? Employer benefits. Small businesses stay competitive and reduce the risk of employees like Mike leaving. Pre-tax employer contribution reduces the amount of employee must pay for the individual health care coverage. Employers can stay in a fully insured market and offer health insurance to certain classes of employees while reducing the cost of and offering a richer health care coverage option for the other classes of employees with an ICRA. Access Health's next step. How Access Health is activating ICRA to help employees like Mike and reduce the rate of the uninsured. Access Health will issue an RFP to select a vendor to choose a solution to help brokers conduct an evaluation with small business owners to determine if ICRA is the right choice for their business and its employees, and assist in the ICRA process. If the ICRA is the right choice, the new solution will be created and will enable eligible employees to enroll on Access Health's enrollment platform. Thanks for everybody's time. If anybody has any questions, please let me know.
John, thank you very much. This is in Access Health's future, and it's important that we understand it. I'm sure we'll hear from you again as the development progresses. But it's an important development that we will see in the future. Paul Lombardo has a question for you. Paul?
Thanks, Charlie. Thanks, John. The HICRA's been around since 2017. ICRA's been around since 2019. John, why now? And has there been any uptake in general in the small group market for this?
So when ICRA came out in about 2019, CUSERA came out in about 2017, and ICRA came out in about 2019, the platform wasn't there, the technology wasn't there to help support brokers and employers to go through the analysis and also make sure that they meet all the requirements for the IRS and all the federal requirements regarding notifications. That technology over the past couple of years has basically exploded. I always give an example to our SLT team. About a year ago, there was probably about 100 individual platforms out there that did this, and kind of most of it was, a lot of it was manual. A lot of the stuff was just kind of pushing, data from one end of the system to the other. Over the past year, over 250 new vendors have entered into this platform. So the technology is catching up, which is making this easier, which is simplifying this, because this is a really complicated topic.
Yeah. Thanks, John. Appreciate that explanation.
You're welcome.
Thanks, Charlie.
Hey, John, can you talk a little bit about the other exchanges? If any of the exchanges are jumping in?
Currently, right now, there's no other exchange. We are in conversations regarding other technology, and I always ask the question, and none of them they currently do not have this on their horizon.
John, Dina Burnham has a question for you as well. Dina?
I just want, so the plans that you would get under this method, they would still be qualified health plans, right? They would follow all of the ACA requirements.
Correct. They're all going to be the plans that are on the Access Health Individual Exchange if they're in that certain class.
Okay, that's great. And okay, no, that's great to know. And I guess I just have to do a little more research because I don't really understand it that well.
It's a tough topic,
But it sounds
absolutely.
great. Yeah, sounds like a great concept.
And
Thank
we will
you.
come back to it for sure. So
Absolutely.
Any other? Oh, Sean King has a question for you.
Yeah, thanks. My question is, do we have any sense of which small businesses are going to be attracted to this? Are we going to be taking business away from the self-funded market? Are we going to be, is this an opportunity for businesses that just don't offer insurance to their employees at the moment? Where do we think that the participants in this ICRA are going to come from, or do we not know yet?
So our initial focus is going to be trying to help out our non-for-profits and working with them and trying to see if we can help them and see if this could be a niche for them. We are going to work with our employers that basically don't offer healthcare coverage but want to use this tool as a way of getting employees and keeping their employees in the marketplace. So that's really going to be our focus in the beginning.
But Sean, to your point, Sean, this will be an alternative to companies who are looking to migrate to the association health plans. This will be an alternative to them. But as John indicated, our primary target coming out the gate would be small nonprofits, who this could be very helpful to them in terms of retaining because they struggle with providing benefits to their employees. So we think this could be very helpful to them. And also, many of them have low wage employees. We think they feel very strongly they could qualify for APTCs if they're in the right class. So we think this would be a win-win for everyone. And also this expands the individual market size. The market size of the individual purchases in Connecticut, which benefits us, but more importantly, provide access to health insurance to more Connecticut residents who currently may not have access to it.
Dina, did you have another question?
I did just, would this also be something that might encourage employers to not use the level funded plans? Like, could it be more beneficial to them than those as well?
We believe yes.
One thing that's interesting about, oh, sorry, yes, that's a very straightforward answer. I like that. Yes, I think it is an alternative. Dina, did you have a follow-up?
No,
one of the
I'm
things
all
that's
set. I
interesting.
was trying to turn my hand off.
No, that's fine. One of the interesting things is it's not limited to small groups. So I think we'll also potentially see larger employers trying to address their part-time employees who don't otherwise qualify for their health plans. I think there will be interesting uses of this option as it matures. So we will keep an eye out. I think anybody who doesn't have coverage today because their employer doesn't offer it, I think this really will be an interesting option for them. So thank you again, Paul, for your update. Any further questions? Otherwise, I'm going to ask Rebecca to return and give us the Leaver survey.
Thank you, Mr. Chair. I'm actually going to turn it over to my colleague, Caroline E. Rouette, who will be kicking us off for this section. So Caroline, back to you.
Thank you. As Rebecca mentioned, I'm Caroline Rouette, Director of Marketing at Access Health CT. I'm here to kick us off with a presentation about the preliminary findings of our Leaver survey. Just to remind everyone what this purpose was really to survey folks who are leaving Husky Health to better understand why they were leaving because of through the Medicaid unwinding process. So I'm going to start by grounding us in the objectives and methodology of the survey. I'll turn it over to Rebecca, who will then share some of the preliminary findings, the key findings, and then I will return to talk about action items and really what we're doing as a result of these findings. So let's kick it off here. What did we learn, or what did we seek to learn? First, we wanted to understand if consumers had health coverage and how they got it. We wanted to know why some consumers do not have health coverage if they indicated that they did not have coverage, and if consumers knew about the Husky redetermination process and what they needed to do in order to retain their coverage. So a couple things there that we were looking to identify. In terms of how we conducted the survey, we partnered with Market Street Research, an independent third party really specializing in research. And we do have that vendor here to help with any questions if there are any. And they helped us develop and administer the survey. The survey was available online and over the phone, so we solicited through both of those channels. And we were sure to do this in both English and Spanish as well. And we conducted the survey between November 6th and December 4th. Now, in terms of who was included in the survey, we reached out to just over 24,000 households that contained at least one individual whose Husky coverage ended between May 1st and October 31st, and they did not have an active enrollment in the Access Health CT system as of November 1st. So that's a pretty key thing, right? We were surveying folks who no longer had Husky Health, so they were leaving, but they did not opt in yet to receive coverage through Access Health CT. So we really wanted to understand why were they leaving and what was their health coverage status. So I will turn it over to Rebecca at this point to share some of our key findings.
Thanks, Caroline. And just to elaborate on that last point, again, why it's important that we understand the population that we're looking at didn't have coverage as of November 1st. A lot of folks we see historically coming off Medicaid, they may enroll later that month and come back on. Or if they're coming onto a QHP, they do have 120 days to come back after losing Husky to come back and enroll in a QHP plan without extra verification steps required. So there is a chance that folks just hadn't gotten around to it. And exactly what we see here, this slide talks about the top reasons why folks that responded to our survey indicated why they didn't have insurance at that point. And we see a lot of reasons here that aren't too surprising. A third of the folks said they had employer coverage. They got healthcare through their job. So that's a very valid reason why they would then come back to the exchange for healthcare, correct? We also saw folks have Medicare aged out. So now they are enrolled in Medicare, or they have coverage through a family member. They were able to enroll on their partner or their spouse's plan or their parent's plan. We did also see a number of folks said that they've moved out of state. as James mentioned, that happens, right? Folks just no longer live in Connecticut. They no longer use our exchange. They may have insurance through another exchange. It's worth noting that that population, if they indicated that they moved out of state, that's where our communication with them ended. We did not continue that conversation with them to say, okay, well, we know you've left Connecticut, but what's your insurance situation? So they are not included in the more detailed analysis and statistics that we have on the population. Obviously, the purpose of what we're looking for, we're really interested in digging deeper in that 29% that responded that they didn't have coverage at the time when this survey was conducted during that month of November. So that's the group we want to dig into a little bit. So if we can go to the next slide.
So why? Can I
Sure.
just interrupt you for 1 second? Matthew Brockman has a question.
sorry about that.
And it may be timely to have him ask it now, so.
Thank you, I appreciate that. How many people actually responded to the survey? I recognize you put 25,000 surveys out there, but how many respondents were there?
We received, there were just under 700 responses. And we did, and that doesn't include, this is a little complex, but there were another batch that did not, that it included the ones that have moved out of Connecticut. They are not part of that 700 number. So they're in addition to. So for the statistical reasons, they are a different bucket. So I believe the number was about I can get you the exact number on that. It's in our detailed report, but memory off the top of my head, it was probably about 730 altogether.
Thank you. That just helped me put this in.
It was as you can imagine at that time of year, and these days a lot of folks, they get another email they may or may not answer. We did offer an incentive, I believe it's a $5 gift card, e-gift card to folks who did take the time to complete the survey as a bit of an incentive to encourage them to participate. So there was that was there to help, but still, thank you for bringing that up, Matt. That does put it in perspective. We also, and again, we're putting, there's a much larger report. I think the full report we received was over 60 pages. We didn't want to inundate you with everything, but the breakdown of the individuals who did respond are aligned with the overall population. For the most part, so we feel it's fairly representative. Obviously, there is that group that says, well, maybe everyone else falls into a bucket that didn't answer, but this is what we have. And again, it's aligned with what our thoughts were, at least on the reasons for leaving.
And can we get a copy of that report at some point?
Yes, once it is completed, we will certainly be sharing it out.
Great, thank you.
All right, thank you. Okay, so again, focusing on that 29% of the respondents that said that they did not have insurance at that point in time. Why? Respondents were given a list of reasons as well as a free form other bucket, right? And they could select as many as they wanted. We weren't saying what is the number one. So, but these are the most commonly selected. The majority of folks, they are saying, well, I didn't qualify for Husky, so I don't have insurance. Well, that's somewhat obvious, right? The reason that they were terminated from Husky during that Medicaid unwind was because they no longer qualified. So yes, we assume that was why. But then the folks were also saying it was too expensive. They were waiting to get coverage through an employer. That happens quite a bit, right? They have to wait till their employer's open enrollment time comes around. Some folks just said they hadn't gotten around to it. That gets back to they have a period of time to enroll, and we've seen that even the Medicaid population after renewals, it takes them a couple weeks to get back in and do that paperwork and get back on. So again, not too surprising on that. They don't know how to get it. That was an interesting one to us because we did hear feedback from folks that they are getting and reading and understanding the materials we're sharing. So that's one we were a little concerned with, and we may dig into that a little bit more as our next steps. Folks are also saying they feel insurance isn't worth it. It takes too much time to complete the insurance, the enrollment process. They don't like the plans. The plans don't cover what they need. or their providers aren't covered by the plans that are available. So a lot of different reasons why folks were uninsured at that point. Some we can certainly, we can step in and help out and try and move the needle on. Others, it might be a little bit harder because they're very subjective and very personal reasons. But again, these are some of the reasons that we're looking into. We're taking these, and I'll turn it over to Caroline to kind of talk about next steps. What are we doing with this information to now improve the process?
Thank you, Rebecca. Thank you, Martin, for turning the slide. Again, this is Caroline Rouette, Director of Marketing, and I'm here to talk with you just a little bit about how we can make this data actionable, to Rebecca's point. So we learned a lot of really great things, and we will be coming back to the board with a more formalized set of recommendations, but these are the areas of focus that we're looking into right now. First is leveraging all available options to make coverage affordable. There are certain limitations that we have at Access Health CT in regard to how we can affect this, but we can continue to address the major barrier of cost by providing a range of plans and by promoting the financial assistance that is only available through Access Health CT. Secondarily here, we need to continue to drive awareness about redetermination. What's interesting from our survey is that more than half of respondents indicated that they were aware of the upcoming redetermination via a state agency and the impact of not taking action. And so I really want to take an opportunity here to thank our counterparts over at the Department of Social Services. We worked really hard together with them to make a really consistent messaging communication strategy. There was a lot of coordination between sending out direct mail, email, and text messaging when we could, since we knew who these folks were, to make sure that they were aware of that. And we did see through the data that those results came through. So thank you to the Department of Social Services for your help in coordinating that effort. Really glad to see this data in our survey. Third here, expanding outreach to groups that are less likely to have health coverage. Nearly 40% of the uninsured respondents from this survey indicated that they do not understand health insurance and therefore find it difficult to sign up for coverage. Rebecca did allude to that as we were going through the reasons why folks are uninsured, and we are going to make this a huge effort. It really comes down to health literacy. We know that this has been a challenge. We have several efforts at Access Health CT to try and combat that, but we need to do more, different, better. And I think we're seeing the need for that really come out of this survey. So we're really focused on these three key areas. And again, we'll be coming up with some more formal recommendations about how we're going to activate this data in our path forward. And I'll pause there for any questions.
Thank you, both of you. Any questions? Really appreciate the information, and we look forward to seeing the detailed report when you send it to us. Thanks so much. Next, Susan, and we are joined again by Julie Andrews, I believe, from Wakely, to talk about the adverse selection report.
Thank you, Mr. Chair. As part of Access Health's enabling legislation, one of our requirements is to have an adverse selection study performed every year to determine if there is adverse selection going on in various market segments, and then look at what can be done to alleviate that adverse selection. So we have engaged Wakely Consulting, and Julie Andrews is here today to present the study. Thank you.
Thank you. Yes, so this presentation is a high-level overview of the study that was provided in the email you received. So the study is a statutory requirement and focuses on identifying adverse selection from 3 potential sources, and then also provides some potential solutions to mitigating adverse selection. So on the next slide, we've defined adverse selection as a market segment attracting a higher health risk versus another. And we're using the risk scores derived from the Federal Risk Adjustment Program and their measurements in the various segments that we're going to be evaluating. Finally, we also measured the loss ratios before and after the Federal Risk Adjustment Program application, just to determine if that program has been adequately mitigating the risk selection amongst the issuers in the marketplace, since it's really currently the only key metric to do so. Our process on the next slide, we kind of did a quantitative and qualitative. So we collected data from all of the issuers in the marketplace that had a sizable enrollment, as well as we did a survey and allowed the issuers to provide their own responses and experiences and concerns with regards to selection in the marketplace. On the next slide, these are the areas of adverse selection that were studied. The first is grandfathered versus non-grandfathered plans, and that is crossed out. Grandfathered plans were plans that were in existence prior to the passage of the Affordable Care Act in 2010. And over the years, there are very few, if none, grandfathered plans in existence. So it's no longer an element of the study. The second is reviewing on versus off exchange plan selections, as well as looking at how self-funding could be impacting the small group marketplace. And then finally, just based on the issuer feedback and what is happening in the marketplace, we bring in other potential sources of adverse selection that are not identified explicitly in the statute for our review. On the next slide, some of these additional options are just regulatory changes and legislative activity that may be impacting selection in the individual and small group marketplace. At this time, as the legislative sessions begin, we're not aware of any significant disruption from that source. The Covered Connecticut program participants currently represent about 20% of the enrollment, and this potential new enrollment from those also unwinding from the public health emergency is really an unknown factor at this point, and how they may impact the individual marketplace as these participants reshape the individual risk pool. So we're going to go on to our first on versus off exchange. For analysis, as I mentioned, we reviewed the risk transfer payments from the Federal Risk Adjustment Program. And so the Federal Risk Adjustment Program sort of seeks to equalize risk in the marketplace amongst the issuers, but it doesn't really do anything to reduce or mitigate the overall risk in the marketplace. So the graph on the left sort of illustrates an increase in the average risk for enrollees off exchange, which are represented by the light blue bars, while the on exchange enrollees risk profiles are represented by the dark blue lines. So in 2021 and 2022, the average off exchange enrollees' average risk scores were 119% of the market average, while those on exchange were 2% below the market average. So indicating that those individuals off exchange have a higher risk profile as measured by the program. So what we think is that this has coincided with the contraction in off-exchange enrollment. So if you look at the graph on the right, you can see that the proportion of the total market from the off-exchange enrollment has declined significantly over the years. It was about 15% of enrollment in 2020, and it's now about 6% in 2023, which is the light blue portion is off exchange, and then the dark blue is on exchange. So the on exchange enrollment has continued to grow steadily, indicating that enrollees could be moving on exchange from off exchange to take advantage of the Covered Connecticut program or the enhanced subsidies that are currently offered through the ARPA and the IRA extension. On the next slide, this is where we look to see how is the Federal Risk Adjustment Program working to mitigate and levelize risk across issuers. So the graph illustrates just simple loss ratios, which are claims over premiums on versus off exchange plans before and after the risk adjustment program transfers. And then everything is compared to an 80% loss ratio benchmark, which is the red line. So in 2022, comparing the two dark blue bars on the left side, which is the on exchange half, the on-exchange loss ratio increased from a pre-risk transfer basis of 88% to 89% on a post-risk transfer basis. So therefore reflecting that risk transfers from on-exchange plans went to off-exchange plans, which had higher risk, as noted in the previous slide. So the 2020 ratios from off-exchange decreased from a pre-risk adjustment level of 94% to 78%. So the risk adjustment program is working at offsetting the high off-exchange risk, but it is an imperfect methodology. You may also notice that there's a lot of volatility from year to year in the loss ratios because we're showing 2020 through 2022. COVID and the policy changes that have been tied to the COVID policy have really contributed to a lot of financial volatility over the years. So on the next slide, wanted to look at another way that potentially selection is emerging as an influence. So we observed an increase over the years in the bronze plans, which are the burnt orange section of the bars. But that trend has now been reversing. So the bronze plans have actually decreased from about 46% of all enrollment to 32%, while the silver plans and gold plans, which are the gray and the gold portions of the bars, have increased. So this shift doesn't necessarily mean adverse selection in the market, but does indicate a preference or selection trade-off. So, what we think is that the lower subsidized premiums under ARPA are driving selection towards less plans with less cost sharing, making them more affordable, as well as the Covered Connecticut program, which requires enrollment in a silver plan. On the next slide, when we surveyed issuers on current and future sources of potential selection in the individual market, so there was an overriding theme that the issuers were hoping to achieve consistency from year to year. The market disruptions over the years with COVID and recent policy legislative changes have made it challenging to gauge and react to potential drivers of selection in the market. So to conclude, the off-exchange market sort of continues to decline in enrollment and deteriorate in average risk relative to the on-exchange enrollment. And what we're seeing is that the federal risk adjustment program is providing protection such that enrollees are not disadvantaged being on versus off exchange. While we also looked at the small group market to look at if there was selection on versus off exchange. However, the enrollment on exchange is very small. It's under 2,000 lives and just was not considered a credible analysis. And so we really weren't able to do an analysis of their overall market shift with regards to that. But we will focus more on a small group market with the self-funding section. So potential solutions on the next slide. Just to continue to monitor the off-exchange enrollment and overall market enrollment and look for options kind of to encourage enrollment and improve the affordability for everyone. From the issuers, they would prefer to review the use of exceptional, circumstance, special enrollment periods, or new special enrollment periods that may disrupt the marketplace and the enrollment. And then there's always consideration of 1332 waivers that may help with the affordability of the marketplace. And these could just be a reinsurance program or expansion of the Covered Connecticut program to help people afford plans going forward. So the next section is the self-funding section. And you can see in the past years, we've run into challenges with regards to collecting information on self-funded plans. Self-funded plans are administered by the Department of Labor and are not necessarily openly reported enrollment experience. And although I'm aware that several of the issuers in the Connecticut marketplace also offer self-funding, we weren't able to really collect any data directly in their survey responses on self-funding in the Connecticut marketplace. So, you know, we did end up having to rely on some national studies and surveys to supplement the study. But we started off reviewing and looking at this small group fully insured marketplace enrollment to determine if there are any changes that could be attributed to drivers of selection. And so as you can see from the graph, looking from the bottom to the top, we continue to observe declining enrollment. There was a 13% decrease in 2021 and a further decrease of about 24% for 2022. And then with, you know, announced issuer market exits in the small group market for 2024 and those that already occurred in 2023, there will be additional disruption as, you know, either those currently enrolled will need to seek new coverage with another issuer or maybe look for other options to provide coverage for their employees. You know, I will say that this disenrollment cannot be fully attributed to self-funding, but in looking at survey responses, you know, we do see that small employers continue to want to provide health insurance coverage to employees to attract new and retain key staff. So the following slide shows an example of one of these surveys. We looked at the employee health benefits surveys that's performed annually by the Kaiser Family Foundation. And the study looks at a lot of feedback and covers both federal and non-federal companies. And what we're seeing over the last 3 years is the proportion of employer groups under 50 nationally that indicate participation in self-funded or level funded plans has remained level. It's about 41 to 42% for the past 3 years. The two sets of the bars to the left kind of break out level funding versus self-funding. And so level funding continues to be the preferred methodology, where the level funding method is a month-to-month payments are held level and the claim volatility is carried in a reserve account, which will be reconciled at the end of the contract term. So it best simulates the fully insured plan. From the survey responses, we asked, about, the self-funding and what issuers are seeing, or if they have information as to where groups may be going. And one of the things that we found is that, anecdotal feedback is that through the underwriting process, as small groups leave the fully insured marketplace, they can see up to 10% savings. All of them do tend to have individual stop loss, which is around 30 to 50,000, which is above the current regulatory minimum of 20,000. We also asked about feedback on, other types of options, the QSERA and the ICHRA, and there definitely is interest in those programs. I think, what they said is that there's concerns or hesitancy just in understanding or doing that leap to get into those programs. So finally, just with conclusions, as I mentioned, there's just really limited data to directly connect changes in the small group market being driven by a shift to self-funding. What we are seeing in the small group market is that the small group premium rate changes have averaged, the requested ones have averaged 14%, but approved changes have been, you know, held level about 8% on average for the past 3 years. You know, it is unfortunate that we've seen some issuers leave the small group marketplace. And with regards to premiums, there are some regions where individual premiums are lower than small group premiums. And so, you know, significant increases in premiums, you know, through the exit of potentially healthier groups could push, you know, employers to consider self-funding options as premiums increase. And so, you know, what we recommend is just the continued monitoring of the small group market and the costs associated with that. And that is the end of the presentation on the adverse selection study. And as I mentioned, the full report was provided. Don't know if there's any questions.
There's a lot of information in your presentations, as always. If I could try a bottom line here, with respect to the individual market, it seems like we are not seeing a significant shift in adverse selection within our population. That is, it looks like it's quite stable. Is that a correct assumption?
That's correct. I mean, the statute was concerned that, you know, on exchange enrollment would be disadvantaged, but actually what we're seeing is that the off exchange enrollment has a higher risk profile, and it's maintained itself over the past few years that we've been doing the study. You know, with the new enrollment driven by the Covered Connecticut program and the PHE unwinding, it'll be interesting to see how that may change.
Yeah, that's an interesting result because that was not what the original assumption was, right?
Mm-hmm.
Interesting. Okay,
Yeah,
any other questions? Oh, sorry, I'm sorry, Jill, please.
Oh, no, it flipped around 2017, 2018, where the off exchange had a higher risk profile.
Yeah. Is that borne out in other states as well? Do you know?
You know, I'm not aware of other states that do this type of study, so I can't say for sure if that is okay. True. But I mean, I think that definitely with the enhanced subsidies and other incentives, there's been a push for individuals to be more comfortable with being on exchange.
Hey, Charlie, it's Paul. I've got a question.
Yes, please, Paul.
Ballpark, can you tell me how many covered lives we have on exchange versus off exchange?
So there's less than 10,000 off exchange. I apologize. On exchange was about the 108,000 that I looked at through last year through 2023.
Right. Okay. Well, you know, as that 10,000 gets lower and lower, it's going to get worse and worse, right?
That's correct. You know, it may stabilize, but, you know, there may be something where the issuers will reevaluate those plans that they offer off exchange. There may be something in the plans, since they differ from those on exchange, that attracts them. I mean, you know, you can buy the on exchange plans off exchange, but I mean, one of the key differences, I think, you know, is the silver loading on exchange. That may be why individuals are picking off exchange.
Okay, thank you.
Mm-hmm.
Any other questions for Julie? Well, again, thank you so much for doing this for us. And Susan, I think we need to give the floor back to you for a vote to approve this survey. Am I correct?
Yes, and I can just, you know, leave it to you, Mr. Chair, you know, to call for the motion.
Okay, could I have a motion to accept the survey as presented by Wakely Consulting this morning regarding adverse selection?
Mr. Chair, Mr. Chair, it's also regarding to accept the 2023 adverse selection study for submission to the General Assembly.
Sorry about that. Okay, so as corrected by Martian, can I get a motion to approve?
So moved, Paul.
Thanks, Paul. Second?
Second, Claudio.
Thank you, Claudio. With no further discussion, Charlie Klippel, yes.
Paul Philpott?
Yes.
Grant Ritter?
Yes.
Deidre Gifford? Steven Hernandez? Mr. Hernandez? Matthew Brackman? Mr. Brackman? Thomas McNeil?
Yes.
Dina Berlin?
Yes.
Peter Hadler?
Yes.
Sean King?
Yes.
And Claudio Gautieri.
Yes.
Thank you.
Thank you all. And again, thank you to Julie and Wakely for the report. Susan, we actually let you have a chance to talk here apparently, so the floor is yours.
Thank you very much, Mr. Chair. I just want to take a few moments to just fill in the board on the 2-month premium initiative. So in the 2023 legislative session, the Connecticut General Assembly passed Public Act 23-204, which among other budget items provides for funding for 2 months of premium assistance through Access Health Connecticut in fiscal year 2024. And this is, as I mentioned, $10 million of funding that is from American Rescue Plan Act Coronavirus State Fiscal Recovery Funds for individuals with income above the covered Connecticut threshold of 175% of the federal poverty level, but below 200% of the federal poverty level, who enroll in a benchmark silver plan under Access Health Connecticut. You could move to the next slide, Martin. So the Department of Social Services and the Office of Policy and Management, as well as Access Health Connecticut, have been having discussions since this item passed in the budget and looking at the best way to recommend to the state to use this funding with the goal of really incentivizing individuals who have not had coverage or who are uninsured to try, coverage through the exchange, people who wouldn't be eligible for covered Connecticut or Medicaid, to give them a little incentive and a little help to try out coverage, and hopefully it will stick. So we've also been looking at possible additional uses of the funding, not just what was specified in the legislation, to really broaden the reach of it, possibly helping small employers on their end if they choose to make ICHRA contributions, broadening the eligible audience who would be eligible for this funding to perhaps higher FPL levels, and to maybe include additional plans in addition to the silver, such as bronze plans, and also maybe looking at supporting infrastructure for new outreach efforts, which could be something like Access Health working with the Department of Labor to get feeds for information on consumers that file for new unemployment benefits. But really the goal is, as I mentioned, the group is really looking at trying to reach the broadest audience possible and really making the most of this funding to really encourage people who are uninsured to come on the exchange and, try coverage, and hope that a percentage of them will stick with it and stay insured.
Thank you. Any questions?
Just a quick comment, Mr. Chair, if I could.
Sure.
So just as we think through this, I just want to remind the board that there are certain deadlines and timelines with ARPA. So as we approach now, this is sort of our third round of ARPA allocations going into 2024. We do need a contract in place to sort of qualify as those funds being encumbered by the end of this year. We do then have a tail afterwards to expend the money, but as we sort of develop the plans, obviously we want high impact, but we also have to be mindful of being able to spend in time so that we're not in a position to turn dollars back over to the Fed. So I know that Susan is certainly aware of that, and it's been top of mind as we scope out something that's still has the most impact, but that can be operationalized. But as the board thinks through and helps flush these ideas out, I wanted to make sure we all operated with that assumption.
Very helpful. Thank you. Thank you. Susan, we're counting on you to.
Yeah, we're all working together. Great minds are working together on this. And just the last item, I just wanted to provide an update on the Health Plan Benefits and Qualifications Advisory Committee. This is the committee that works with the plan management staff at Access Health on the qualified health plan certification requirements, primarily the standard plan designs each year. So as we always talk about this group, and the plan management department is always thinking in advance of everyone else. A lot of our focus today has been on the numbers and for this open enrollment period that just ended, but this committee and the plan management team is focusing now on 2025, plan year 2025. So we have our meeting scheduled. The first one will be held next week with the committee on January 25th. And then we have 2 meetings scheduled in February 7th and February 20th. And leading up to all of this, Wakely has actually been working with the carriers and working with the draft actuarial value calculator for plan year 2025, which was released a few months ago. It hasn't been finalized yet, but it's out in draft. And so we start our work by putting the current year, the 2024 standard plans into the 2025 calculator and seeing if anything is outside of the AV range, acceptable range, and then also thinking about what possible changes would the committee like to recommend to the board for the plans to make them, better for our consumers. So all of this work is done so that the plans can be approved by March, because we have to back up to the deadline. June 1st is the deadline that the carriers have to file all of their rate and form filings with the insurance department for plan year 2025, and Access Health ties its filing deadlines for QHP applications to the same thing to make it easier for the carriers. So both of those deadlines are June 1st. So we want to get everything approved in March so that Access Health can post its solicitation before the end of March and get all those materials out to the carriers to give them plenty of time to do the work that they need to do on their end to develop the plans and the proposed rates for their filings. So that is the update.
Thank you. Any questions about the update? Hearing none. James, the floor is yours.
Thank you, Mr. Chairman. Just a couple of items looking forward. Now we're going to come back to the board with with more detailed ICHRA development, and we're also looking forward to the board sometime in March have a special board meeting for the board to approve the proposed or recommended plans from the HPBQ team, and also we're going to come back to the board with the final leaver survey at the next regular board scheduled meeting. And then I want to remind the board that we don't have a meeting in February or March. The March meeting will be a special meeting specifically dedicated to reviewing, and possibly approving the recommendations from the HPBQ committee of the board. Thank you, Mr. Chairman.
Thank you. Any other questions or comments before we adjourn?
Mr. Chair, I wasn't at the, sorry. If I may just say, I wasn't at the last meeting where Dina was formally introduced, but I have known her for a while as someone in the Senate Democrats office who's brought some brilliant policy expertise to the healthcare and affordability space. And I'm just thrilled that she'll be joining us and that we all get to benefit from her input on this board. So I appreciate you giving me a moment just to say that, as I was not able to see her at her first official meeting.
Hear, hear. Dina, it's great to have you on the board. Thank you very much.
Thank you. Thank you all.
One quick observation, we're in the middle of a fiscal year here, but I'm reminded that the calendar year 2023 was a challenging one for the exchange, particularly with the unwind. And I think credit to the team here for taking that in stride. It was a challenging year, and I think you've done great work in seeing us through that transition and trying to capture as many people as possible falling out of the expansion. So great work. Really, really appreciate it.
Thank you, Mr. Chairman.
With any other comments or questions? Otherwise, I would have I would be corrected by Marson here, but could I ask for a motion to adjourn this meeting? Anyone?
McNeil, so moved.
Paul,
okay.
second.
All right. Tom and Paul, thank you
No
very
second.
much.
Yeah.
Yep. Thank you. Marson, with no further discussion, Charles Klippel, yes.
Thank you. Paul Philpott,
Yes.
Grant Ritter,
Yes.
Teacher Gifford, Steven Hernandez, Mr. Hernandez, Matthew Brackman, Thomas McNeil,
Yes.
Dina Berlin,
Yes.
Peter Hadler,
Yes.
Sean King,
Yes.
and Claudia Gautieri.
Yes.
Thank you.
Thank you all very much. See you at our next meeting.
Yes, thank you.
Bye-bye, everyone.
Yes, hello. All right. Hello.